Okay, so welcome everyone to our special webinar in celebration of the World Kidney Day 2025. I'm Augusto Santos Jr. I'm a nephrologist based in Brazil and your host for today's session. I'm also honored to be here with all of you to spread awareness about kidney health. The World Kidney Day is a global campaign that aims to raise awareness about the importance of kidneys and to reduce the frequency and impact of kidney disease globally. The 2025 theme campaign is Are Your Kidneys Okay? Detect Early, Protect Kidney Health, emphasizing the need for education and preventive measures to ensure better kidney health worldwide. We have a fantastic lineup of speakers today who will share valuable insights on detection, prevention, and treatment of kidney disease, promoting kidney health. We will start by welcoming the president of the International Federation of Kidney Foundations, World Kidney Alliance, Alessandro Balducci, and also the president of the International Society of Nephrology, Marcello Tonelli, who will provide us with a brief overview about the 2025 World Kidney Day campaign. They have recorded a message, and we will start the recording message from both now.
Welcome to this 2025 World Kidney Day webinar. I'm Alessandro Balducci, President of the International Federation of Kidney Foundations, which is organizing this webinar and the World Kidney Day together with the ISN, International Society of Nephrology. For this year, we have chosen a theme that is, Are Your Kidneys Okay? Detect Early, Protect Kidney Health. What does it mean? Well, first of all, it means that we need a new urgent action for early detection in high-risk group, which are people who are affected by diabetes and hypertension. Millions or milliards, maybe, of people all over in the world. And these are the two main causes of renal disease. So for protecting kidney health, we might have an action of prevention in reducing the burden of kidney disease. Don't forget that renal disease is actually the 8th cause of death, but in 2040 is projected to become the 5th cause of death all over the world. So we need stronger policy and strategies to improve kidney health. So please, all of you, participate in the World Kidney Days that is taking place in more than 100 countries all over the world with thousands of events and manifestations. Please go everywhere and participate. Thank you.
Welcome to the 2025 World Kidney Day webinar. I'm Marcello Tonelli, President of the International Society of Nephrology, and it's a pleasure to welcome you to this important discussion. Kidney disease is often called a silent killer because it can go unnoticed until significant damage has already occurred. Kidney disease is on track to become the 5th leading cause of death in just a few years from now. Right now, Guatemala's exciting kidney health resolution is under discussion among WHO member states for approval at the World Health Assembly in this May. The resolution is a crucial step towards ensuring that the prevention and control of kidney disease receives the global priority it deserves. We applaud Guatemala's leadership in spearheading this resolution, and we look forward to working with their leadership, including Minister Dr. Joaquin Barnoya, to ensure its success. The theme for this year's World Kidney Day aligns perfectly with the goals of Guatemala's WHO resolution by emphasizing 3 things. First, the urgent need for early detection of kidney disease, especially in high-risk groups. Second, the critical role of prevention in reducing the burden of kidney disease and kidney failure around the world. Third, the need for stronger policies and strategies to improve kidney health everywhere. In the webinar, we will hear from leading experts who who will share key insights on risk factors for kidney disease, strategies for early detection and prevention, and practical tips for how to protect kidney health. Thank you for being part of this global movement, and enjoy the webinar.
Thanks, Marcello Tonelli and Alessandro Balducci, both presidents of the International Society of Nephrology and of the International Federation. And this was really brilliant. I hope you are all excited because I am. And without further ado, I will now introduce Dr. Anna Francis. She is a pediatric nephrologist and also a clinician researcher at Queensland Children's Hospital in Australia. She also recorded her talk today and will be helping us to set the scene and addressing understanding kidney disease and risk factors. So thank you, Dr. Anna Francis. Let's start this talk, please.
Welcome, everybody. My name's Anna Francis. I'm a paediatric kidney specialist from Australia. And I'm talking to you today about detecting kidney disease early to protect our kidney health. So we're going to talk today about what is kidney disease, who is at risk, and why and when should we test for kidney disease. So chronic kidney disease, or CKD, is defined as abnormalities of how the kidney is formed or how it's working. And they need to have been there for at least 3 months before we can call them chronic. And they also need to have implications and affect someone's health. So chronic kidney disease actually affects 10% of the world's population. But of the people who have chronic kidney disease, about 90% of them are unaware that they have it. When we think about chronic kidney disease, we think about 3 different areas to it. We think about why someone has it, kidney disease, and we think about the severity of it. And we use a urine test for protein in the urine and a blood test called creatinine to have a look at that. So let's go through that now. So kidney disease can be caused by a wide range of things. Some of the most common are diabetic kidney disease, or kidney disease in people who have type 2 diabetes, or type 1, which is the insulin-dependent diabetes. You can also get chronic kidney disease secondary to high blood pressure, cardiovascular disease, or obesity. And of course, those 3 things are often overlapping and occurring in the same person. Autoimmune diseases can affect the glomerulus, which is the filtering component of the kidney. And kidney disease can also run in families and be caused by genetic conditions. Some babies are born with structural abnormalities. We call this congenital, which means just born with it. For example, having only 1 kidney instead of 2, and that 1 kidney is not quite made properly. And then things like infections or certain medications or toxins can also damage the kidney and cause lasting kidney disease. When we think about how we define the severity of the kidney disease, we use this blood test called creatinine, and that's used to estimate something called the glomerular filtration rate, because filtering blood is one of the main jobs of the kidney. We use creatinine, we use gender and someone's age to use this. And in children, we also use how tall they are as well. And we can use that equation to come up with a number. We call that the estimated GFR. And that can be scaled between G1, which is really very normal kidney function, all the way down to G5, which is an estimated GFR of less than 15, and that's consistent with kidney failure. We also look not just at the filtration rate, but we also look at the level of albumin, which is a protein in the urine, as a marker of kidney damage. And if there's a persistent protein in the urine across time, then we know that's consistent with worsening kidney disease. And we grade that from levels of A1, A standing for albuminuria, which is really essentially normal, through to A2, moderately increased albumin or protein, and A3, which is severely increased. And then we can put that information together. On the left-hand side, we've got running down the left, we've got the G categories, the glomerular filtration rate, and running across the top on the right, we've got the levels of albumin or protein in the urine. And then you can go to where they meet, put them together, and find the risk for progression to kidney failure or progressive severe kidney disease, with green being very unlikely, yellow being moderately increased risk, orange being high risk, and red being very high risk. So who is at risk of kidney disease? Well, as we mentioned before, diabetes, high blood pressure, cardiovascular disease, and obesity, and family history and genetic conditions all play really major roles in the formation of kidney disease. But there's lots of other things at play as well. There can be environmental risks, for example, snake bite. Different agricultural communities around the world, with agricultural workers, particularly in hot areas, seem to have clusters of chronic kidney disease that we don't fully understand. We call that CKD of unknown, CKDU unknown. We're still trying to figure that one out. We think climate change will probably play a role with increasing heat, particularly in these agricultural workers. And then cancer, autoimmune diseases, and other health conditions can also affect the kidney. Pregnancy is a really interesting one. So preeclampsia during pregnancy really increases a woman's risk of developing chronic kidney disease in later life. And babies who are born small for the age that they're born at, or who are born preterm, are also at increased risk of chronic kidney disease. And then overlaying all of this are things that can impact ability to access care, for example, wealth, education, health literacy, whether you live in a rural or remote community compared to a city, and of course the wealth of the country that you live in. So all of that interplays with all of the other risk factors. It's also important to note that the risk changes throughout life. So it's not just a static thing, and we have to think at different phases of the life course. What could be the different risks that might actually increase or decrease the risk of chronic kidney disease? And then I think one of the really important questions is, why should we test for kidney disease? And the answer is because there is so much that we can do, particularly if we diagnose the kidney disease early. There's lifestyle interventions, healthy diet, physical activity, quitting smoking, weight management, that can make an enormous difference to kidney disease risk. And then on top of that, we've got drugs and medications that we can use, both to slow the progression of kidney disease, to try and prevent complications, or to decrease the severity of complications. So there's an enormous amount that we can do. We definitely want to test for kidney disease. And the next big question is, when should we be testing for kidney disease? And to answer that, I'm going to hand over to my colleague, Professor Joseph Bassilotti. Thank you so much.
Okay, thank you so much, Dr. Anna Francis, for putting a framework and setting the scene of kidney disease and helping us to understand risk factors and where preventive measures might apply. Now it's time for panel discussion, where we'll try to address and debate primary and secondary prevention strategies for kidney disease. We will have three distinguished speakers helping us to debate this issue. A nephrologist, which is Professor Joseph Bassilotti. Professor Joseph had some issues connecting. He's chief of a medical officer of the National Kidney Foundation and also a professor of medicine in the Division of Nephrology at the Icahn School of Medicine, Mount Sinai. He's also a co-investigator of the CDC Prevention Chronic Kidney Disease Surveillance Project. Let's see if he's able to connect. If not, I will try to help on the debate. We'll also have a renal dietitian, Professor Claudia D'Alessandro. She's affiliated to the Department of Clinical and Experimental Medicine at the University of Pisa, Italy. And joining us also a kidney patient representative, Mrs. Hajalasmi Havi. She's head of the Tanker Awareness and Prevention Program. And hopefully now we will have time for discussion. And in this regard, I also would like to ask all who are attending this session that we will be open for questions from the audience. So please type your questions in the chat box so that we will be able to hopefully address as many as possible during our discussion from now on. So welcome, Claudia. Welcome, Hajalasmi Havi. Let's wait a bit for Professor Joseph, but shall we start with your points and ideas?
So, okay, I can share my presentation or, okay?
Sure.
Okay. Okay, can you see the slides?
Yeah, we can.
Yes, I try to be more practical as a renal dietitian to be, sorry, the presentation, okay. So thank you very much. I'm very honored to be here today. I think there are many patients connected, so if there are, if what you don't agree on what I'm saying, please comment, and I will be very happy to answer your questions. So this is just like the thread of my speech. I try to explain why the renal dietitian needs to change the approach to improve patients' adherence. I'm working with renal disease for 28 years, and I changed a lot my way of working with renal disease. And I started when many years ago, focusing my attention on the renal diet. But now I focus my attention on patients, on CKD patients. And then I try to give some practical advice and some strategies to improve adherence to the diet. So why I change my way of working with renal disease? Because people are very different from each other. I have old people who have problems with going to do shopping, with also preparing food. I have, in the last decade, I see an higher prevalence of obesity. I have patients who don't agree to avoid some food. I have people who need a lot of energy because, for example, for their job. And I have people from different countries with different dietary habits, tradition. So this is why the typical dietary pattern prescribed mainly on the residual renal function, even if it's well calculated by a renal dietitian, is not enough to improve adherence to the diet, because we have to what is very important, to start from the patient, work with the patients to answer patients' needs. So dietitian, this is the typical path that dietitians generally follow. And we start from the nephrologist dietary prescription, clinical data collection, and we have a very strong tool, a very important tool, that is dietary recall. Dietary recall is very important because I used to say to my patient, with the dietary recall, I enter patient home, because I'm able to understand dietary habits, but also lifestyle, if there are social or economical problems. So it is very important, because with this information, I'm able to plan a very tailored dietary plan. So generally, but generally what I used to do, I prefer a stepwise approach. So starting with some simple recommendation that I resume in these 5 points. So I start trying to limit salt use, and obviously I give my patients some practical advice on how to make food tasty without adding too much salt. And I also limit those food who are rich in salt and from food that I'm not able to remove salt. So sausages, salami, cheeses, and first of all, canned preserved food. I try to limit also the animal sources of protein and prefer vegetable sources. For example, I ask my patients to use fruits and vegetables that sometimes they avoid because they are afraid of potassium level, of increasing potassium. But we know that fruits and vegetables are rich also in fibers and have an high alkalizing powers that is it's very important for our patients. And the 5 point, I try to ask to prefer or to substitute animal sources of protein with vegetable sources, because they are generally, I tell my patients that vegetable protein reduce the workload, the workload of our kidney. All these tips I talk about are contained in the Mediterranean dietary pattern that 2 years ago we added some changes to Mediterranean dietary pattern to adapt more this pattern to patients, to CKD patients. And when the metabolic balance starts worsening, I add some new recommendation. I go on with a gradual protein restriction and reducing protein. We also reduce phosphorus intake, because there is a strict relation between protein and phosphorus content in food. And in Italy, we also use special product, protein-free products, which helps us to give energy, but reducing protein, salt, and phosphate intake. Generally, I try not to ask my patients to avoid some food, but I work with the frequency of consumption and with the size of the service, all those food that are not so good for our patients. Because sometimes if we ask to avoid something, immediately we have a strong desire of that. So working with the frequency of consumption and size of serving, we help our patients not to have good control without restricting too much the diet. I always use some counseling tools, generally colored and with because I talk a lot during my visit and my patients are not able to remember everything when they are at home. So using this tool with images and with colors during my speech, generally they are facilitated to remember what I say when they come back home. But what I prefer above all is the use of recipe, because I use recipe as an educational tool for personalized counseling. And why I prefer this kind of tool? Because these are a recipe book for patients on dialysis, but I have also recipe book for patients on conservative therapy. Generally, I use the list of ingredients to substitute food that are not good for my patients with more advantageous one. And in the preparations note, I suggest some methods of preparation and some cooking methods that are useful for my patients. And with this method, patients become able to modify every kind of recipe they prefer in order to have a diet tasty, but that is in accordance with the recommendation for CKD patients. And this is our famous recipes on lasagna, that have been adapted for patients with CKD, and it is contained in the World Kidney Recipes. But we can also do more. Sometimes I say that I'm also a biologist, and first I used to work in a lab, and now today as a dietitian I use my kitchen as a lab. So I make experiments with different kind of ingredients. And for example, in this recipe, we can also calculate the potential renal acid load of a recipe. So we can use ingredients to make very tasty but very useful recipe for our patients. And this is another event. I bring my patient in a kitchen, and this is the kitchen of a school for young chef, and I prepare this young chefs to explaining the renal, the principle of renal diet and dietary habits, the dietary recommendation for CKD patients. And I prepare some recipe, and I give my patients the ingredients, and here my patients cook for themselves. And while they were cooking, I try to explain why I told them to use one ingredient instead of another one, why I asked them to do some preparations and to use some cooking methods instead of other. So they are they become very skilled in prepare food for themselves. And then, and this is the result, as you can see, the result of our experience. The early diagnosis, like Dr. Francis said before, is very important. Follow-up is very important. And my patients are very happy when I do all this evaluation to study muscle performance, because they are curious of understanding what the diet they are following, what the diet they are following is good or not for them. Exercise is very important. It's part of my dietary plans, because if patients exercise, they feel well. And what is very important for my patients to keep in touch, so to answer questions when in every moment, so they are always followed by us. So to conclude, dietary therapy is a very important therapeutic option in CKD. Dietitians need to start from the patient and work with patient and family and caregivers. And we need to give solutions instead of prohibition, and to create a new eating style. But sometimes I ask my patients to remember that there is more than food, like exercise, like living together, like socialize, because this is very important to feel well. Many thanks.
Okay, thank you so much, Claudia, for these amazing insights. I just want to remind that we have 8 golden rules, and I'll just list them. I hope we have time to discuss them. So first, keep fit and be active. Second,
Yes.
eat a healthy diet. Third, check and control your blood sugar. Fourth, check and control your blood pressure. Fifth, take appropriate fluid intake. 6, don't smoke. 7, don't take over-the-counter medication, especially anti-inflammatory painkillers regularly. And 8, get your kidney function checked if you have one or more high-risk factors. So with all that in place, I would like to hear from Havi, her opinion and insights, So we just heard so many important instructions, and from the perspective of the patient, so how difficult is it to put all of this into practice? Please, Havi, open your mic and let's hear from you, your insights and thoughts about that.
Yeah. Good evening, a very good evening to the esteemed panelists. I'm Rajalakshmi Ravi, advisory member and heading Tanker Awareness and Prevention Program, Tanker Foundation from Chennai, India. I extend my heartfelt thanks to the ISN Academy for giving me this opportunity to connect to the luminaries in this field across the world. I'm here to throw some light on the scenario of CKD in India and our work on this direction. To put things in perspective, India's population is 1.43 billion as on 2023, and of this, 212 million people are diabetic. Lack of awareness and poor compliance to treatment are the main reason why 30% of the diabetics end up with CKD, with a prevalence of 17.2% according to recent studies. As much as the country, India is progressing in science, technology, education, infrastructure, finance, commerce, and healthcare also, there is an increased surge in the lifestyle diseases. Considering the large population and complex healthcare challenges, predominant focus is being given to the prevention and cure of communicable diseases at the policy level, which is a recurring expenses for the government. Therefore, the country has been witnessing an unmet gap between the demand and supply of healthcare infrastructure, specifically with respect to NCDs and in particular chronic kidney disease. The most tangible solution for this challenge as far as the developing countries are concerned is to create awareness among the general public, particularly those who are at risk. In Tanker Foundation, we started this Tanker Awareness and Prevention Program 20 years ago. We call it TAP, T-A-P-P. The program is planned to conduct awareness programs aided with PowerPoint presentation. The presentation discusses and explains what kidney functions are, what are the causes for kidney disease, namely diabetes, hypertension, proteinuria, self-medication, alcohol, smoking, and drugs, and highlights the simple tests, a urine test for early detection of kidney disease. These are explained in the form of a PowerPoint presentation in English and in local languages also. We address all sections of the society, particularly school children, in the hope that they will take the message to the parents. And we also speak to the uneducated sectors like the truck drivers, construction workers, and other farm laborers. We also distribute educative materials with pictorial depiction in case they are not able to read. And we also conduct screening programs for early detection. And as I told earlier, a lot of awareness is not there. People do not know what diabetes is, what hypertension is, and they do not understand that these two can connect or be the cause for a non-communicable disease. And in our screening camps, we check their BMI, blood pressure, random glucose, urine test for protein and glucose. A doctor would give an appropriate advice and prescription. As one of the 8 golden rules says, even if a person has 130/80 blood pressure, we give a lot of counseling to them saying that please be aware that you should not overgo beyond this. And similarly for random blood sugar also, people may be well within the range with medication. But we talk to them and tell them it is very important to follow the lifestyle changes also, and adherence to medicine, both should go together. Lifestyle changes, compliance to drugs should both be followed in order to maintain the blood sugar level well within the range. And so far, we have conducted 1,468 awareness programs in the period of 20 years, reaching out to nearly 210,000 people for awareness programs. We have conducted 577 screening programs, reaching out to 44,000, nearly 45,000 people. On an average, we conduct 6 awareness programs and 6 screening programs every month. The per capita income in our country is 6,602 rupees, maybe roughly about 75.8 US dollars. And a lot of the treatment for chronic kidney disease is extremely painful, extremely draining financially and socially. So the cost of preventing kidney disease, we calculate, is more feasible according to our screening programs when we do these basic screening tests and alert them to follow these guidelines. It costs us only 200 rupees per year. So we advise them to go for these simple tests, if not once in 6 months, at least once a year. A lot of awareness and non-compliance of drugs is the main problem in India. In Tanker Foundation, we are striving hard to step up both awareness and screening programs. We also make review calls after the screening programs to ensure longitudinal screening and testing. So in this way, we look forward to screening a lot more people and creating more awareness about not only kidney disease, but the causes which leads to kidney disease. Thank you.
Thank you so much, Hajalas Mihavi, for your insights from the perspective of the patient and so many practical actions that are being taken in India. I just want to kind of draw a parallel. In Brazil, we have increased exponentially the number of patients on dialysis in the last 20 years. So we went from nearly 30,000 to almost 170,000 patients on hemodialysis in 20 years. But we are still only around 700 patients per million inhabitants in terms of the rate of patients in dialysis compared to other countries where this number reaches close to 2,000 patients. So there is still much to do in terms of education and awareness. And besides that, screening for kidney disease is quite simple and very cheap. checking the creatinine and doing a simple urine tests is quite accessible all over the globe. So I really wanted to add this information so that you can comment on this. So what are the challenges that you see in Italy and also in India that we can probably sharing to other countries? And how do you manage to overcome these difficulties in your location? If you both Claudia and
Okay.
Hajalafmi can tell us about your experience on that.
Hajalafmi, I start. Can I start? Okay.
Yeah.
Okay.
Yeah, sure.
So I think that Italy and India are two different situations. This is very important because, for example, when I perform my evaluation of the nutritional status evaluation, there are we talk about malnutrition, but we talk about mean the average values, but things in Italy, Europe, and other countries are completely different. This is why I was talking about start from the patients, because there are the economical situations that are completely different. So we have to analyze what is the habits and lifestyle of patients before telling what to do. For example, in Italy, when I started working with renal disease, the main problem was to help our patients to have good nutrition because they eat not enough. Now I have the opposite problem. Now I have obese and overweight patients. So I had to change my way of treat patients. Many years ago, I never talk with obese patients. Now I start to change my way of approaching patients because I need to help them to lose weight, because otherwise they cannot enter transplantation list. Okay, so what is very important for me, it is to a strict collaboration with general practitioner to start with an early detection of alteration of blood exam, but first of all urine test, because creatinine, for example, is also influenced, for example, by muscle mass or dietary habit, not good dietary habits. But urine test, that is very simple to perform, I think it is the first things we have to do. And I would like also to start, for example, in the school, to go in the school to start with this screening. I think it will be very important to have an early detection of some alteration that probably could be nothing, but we can start immediately to do something. Sorry, like Rachel asked me, I talk too much.
No.
Yeah.
Can I speak?
Sure, please.
Yeah. We started doing for school children only awareness programs. We do not do screening program for the children because the prevalence of diabetes or hypertension or any abnormality in urine will be almost negligible in children.
Okay.
And looking at the lack of awareness about everything, we don't want to panic the parents saying that we are going to do some kidney screening program. Even in adults, when I go for a screening program, the adults think that I am going to bring a lot of machines to do the screening for the kidney functions. So it is very difficult to explain to them that a simple urine test is the most important tool or a test to even identify or tell them whether an individual is at risk for getting kidney disease or not. If a person shows proteinuria 1 plus or 2 plus, we give them a lot of advice saying increase your water consumption by at least 2 more liters.
Yeah.
And we tell them control your blood pressure, control your obesity, overweight. So then if it's repeat the test, we always ask them to repeat the tests after 15 days. That's why we do review calls after 15 days, asking them, have you done these tests? It is only after getting the review calls, they realize, oh, it is so important that I should have done these tests. And then they tell us, I didn't understand, madam, now I will go for the test again. So, according to our studies, it says by end of 2025, in India, 18% of the men and 21% of the women would be obese. And our Prime Minister is advocating that obesity to be controlled this year in a very large, war footing, and consumption of oil should come down. And we are now reading, particularly in India, a lot of children are obese, as you just mentioned. Obesity is seen in a very large numbers among children, which was not there about 25 years ago. And those who have early, even if you detect kidney disease early, people in the rural areas do not have sufficient infrastructure, medical infrastructure. Particularly, they do not have nephrologists in tier 3 cities and in the rural areas. So they shift to metropolitan cities or in the capitals, and that really dislocates the family and their socio-economic structure a lot. And people have to understand that they don't still understand that diabetes is a non-communicable disease and it is an individual-centric problem. Similarly, hypertension. They think they take medicine for 1 month. When we go for camps, we talk to them, why is your blood pressure so high? They say, I was taking medicines for a long time. It was normal, so I stopped. They think it is like any communicable disease, like a cold and fever and diarrhea. Like you take medicine, you become all right. So diabetes becomes all right. BP becomes reading is normal. Then you can stop the drug and go away. So we need to create a lot of awareness about these lifestyle diseases.
Yes.
As our country progressed slowly, a lot of lifestyle changes, standard of living increased. This led to obesity, changes in negligence, and not able to adhere to the blood tests or any guidelines that they are not able to correlate both. So a lot of work is to be done still.
To be done. Yes.
Yeah, so that's brilliant, because actually that illustrates very well why the campaign is kind of moving from the nephrology community to address general practitioners and also the family of the patient, so the community. Actually, we all know how difficult, despite being very simple 8 rules, the golden rules are kind of easy to understand and to connect to them, but we all know how difficult that they are to be put into practice on a daily basis, and therefore usually the patient alone will not be able to do the movements by his own resources. He will need the family as well to change habits with him, promoting a healthy lifestyle. And of course, we'll have to connect to the general practitioner to help us identify patients at risk, which are on the early stages of kidney disease. We are receiving so many questions. And one of them connects to what we are just discussing, which is so who are the community or the patients who should be on the spotlight of screening for kidney disease. And we all know that diabetes and hypertension are the driving force globally, together with unhealthy diet and obesity. So metabolic diseases are the driving forces for increasing kidney disease globally. So I really would like to hear from you. What are the misconceptions that you encounter on a daily basis that prevent people for changing and acknowledging the need for change on a daily basis? So on your routine discussion with patients or with your community, in the case of Shalami, what are the most difficult turning points that you have to make patients change the habits?
Okay.
You're asking me, sir?
Yeah.
So in our screening program, we people think screening program for screening camps for kidney disease are meant for people who have the problem. No, we are conducting the screening programs for the normal people who don't have any complication, who don't have any abnormality. The camps are open for everyone. Everybody should come and get tested, because in India, 50% of the population, I mean, that is said in one of the golden rules. They do not know whether they have diabetes. Another 50% of the population do not know whether they are hypertensive. And this is one section of the population where every normal person, the, the, the rule or the statement that we say is that even if you are a normal person, even if you don't have diabetes or hypertension, come and get checked and ensure that your values are well within range. And also the people who have diabetes and blood pressure, they do not have, as I mentioned, they have, the compliance is very, very low. They don't go for regular checkup. They continue to take the tablets which the doctor gave them 5 years ago. They would not have tested their blood at all after that. So definitely when you test their blood now, it shows very high in sugar. So they do not understand that periodic testing helps them in altering the medication or any other lifestyle changes or any modification, diet modification, as ma'am said. So these are things that we meet in every day when we come across people in the camps. After attending the camps, only people are able to correlate diabetes with kidney disease, hypertension with kidney disease, obesity with kidney disease, and proteinuria with kidney disease. Otherwise, they think, oh, kidney disease means it is something only nephrologists can address. And only people who have some problem should go for screening. And only with the help of large technology, big machines, kidney test is to be done. So we need to tell them that it is not at all like that. It is all a myth. Very everyday simple test. Because many times people ignore urine test reports. They concentrate so much on blood test. What does my blood test say? What does it say? They don't really know that there is a lot of message given in the urine report.
Yeah, that's great. And that connects with some of the questions that we are receiving now. So, which are one of the questions is what are the common signs? So, actually, kidney disease is a silent disease for most of our patients, especially in the early stages. And this is why screening and checking individuals is important. Another very important question that we received refers to, is it possible to stop the disease? actually we have so many tools nowadays. Treatments have evolved so much that it's even possible to improve your kidney condition in terms of health, depending on the underlying disease that caused that chronic kidney disease to unfold. So prevention has become the most important action, is as we are really struggling to treat patients with late stages where technology is very much needed, the costs are higher, and patients will eventually also have to dedicate more time, and eventually the quality of life of these patients in these late stage treatments will be worse. So what we really are in need nowadays is a global effort in order to prevent patients to reach end-stage kidney disease, and that of course pass through having detection in early stages and starting treatment as early as possible. Claudia, I yeah, also wanted to hear from you. So when it comes to diet, we also have a huge global problem in terms of fast food, high salt food,
Yeah.
and so on and so forth. So industrialized food, why is it bad for kidneys? Can you explain it to our listeners now?
Yes. Yes. Today, it's very difficult because people have no time for anything, and no time also to sit to have a meal. So when I explain how to manage the diet, I have to explain how to behave with food. And sometimes I work, as I told you before, I work with the recipe because I had some time to explain that to cooking something good, tasty, and simple needs a few time, because people think that that buying something is easier, no? And but when we buy something that is already food, already ready to eat, or need also to be warm, generally is food that has been preserved, a lot of additives, salt. And so I try to explain my patients how to prepare food easily, with that need with less time, with few time, because fresh food, to have fresh food is the best things for us. I know that we have no time to go to do shopping every day. So we need to go to the market. In general, we do shopping for all the week. And so if we buy food like that, we need to buy food that can be preserved for a long time. But generally, I tell my patient, I give you a dietary plan, not because I want you to follow everything, but consider it the least to go to the shopping. So I help patients to manage food in the most simple way. And it is very difficult, because what we ask our patient is not to follow a diet, but to change lifestyle. So I bought something ready to eat. No, I tell you to buy ingredients and to prepare food. So I force my patient to change what they are used to do. And I have to explain that it is easy to do. This is why I talk a lot with my patient, because I have to convince them that it's better to do this rather than to buy prepared food. So I know that it's not easy for that, but I'm also a patient. So I know that it is not so easy to follow some recommendation, and considering what I do for myself, I try to transfer this my experience with my patients.
Yeah,
I know
great.
that it's difficult, but
Yeah. And I always talk to my patients that, you know, healthy food can also be tasty. So, you know,
yeah.
we are not they have also the chance to keep the pleasure of eating. It's not only about restricting.
Yeah.
Okay, so time is running fast, and I would like then to have your final thoughts. Please, can you do your in very brief statement? Can you bring your final thoughts on all that we have discussed? A brilliant discussion, very rich session. Thank you for that.
Yeah, I can say again that I'm very honored to be here today, and because sharing experience is a way to learn something or something more. We have to learn, and if there are patients connected today, I would like to ask them to ask your dietitian, your nephrologist help, and don't think that you have to change to follow the restriction or something like that. We can live a happy life also with the disease. We need to understand how to change, but we can. I know that we cannot accept a chronic disease, but we have to try to live anyway also with the disease. So to learn a new eating style and a new lifestyle.
Thank you. Javi, your final message.
Yeah, thank you. I'm really honored and proud to be on this panel, and thanks to everybody. The 8 golden rules that we have put up in the WKD ISN channels are really great. So diabetes, blood pressure, obesity, and urine tests, drinking plenty of water is very important. Sometimes we don't understand that we are getting dehydrated. So drinking plenty of water is very important, and tobacco and usage of drugs are to be avoided, and particularly regular exercising is a must. It is not to shed weight, or it is not to do this or do that. The blood circulation should be normal, the muscles to be active. We need to be having a good life and a healthy life. For that, we need to either walk or jog or play some games and be active. And screening is very important for everybody. It is not for people who are sick that should go and get themselves tested. Everybody should have the mindset to get themselves tested at least once a year. Need not go for massive health checkup or master checkup or any corporate screening. Very basic tests like diabetes, blood pressure, obesity, urine test, and ECG will be quite fine. With that, compare the reports. Keep your reports safely. So compare it with your last year's values. Have you gone down? Are you stable? Are you going up? That evaluation has to be done. And a lot of awareness, and whatever we know, we need to share with our friends and try to educate them verbally, because how much ever people you ask them to read this paper, read this magazine, they will not. Wordly, by verbally, if you tell them something, peer pressure is most powerful. If you tell 100 people, at least 10 people will listen. And I hope some people have benefited by this talk. Somebody had asked a lot of questions. Hope we have answered their queries. They can always get back to us with their website, and their email will be there in their website. Tankerfoundation.org is there. candor. Thank you once again for this wonderful opportunity. I hope I had spoken well. Thank you. Namaste.
Really beautiful. We received so many questions. I'm for sure we'll make the way of these questions reaching to you. So a big thank to our speakers today and for everyone who made this possible. Thanks for all who have attended this webinar. We hope you find it the information and the session informative and empowering. I also would like to ask you to please follow the World Kidney Day on social media and also the website. There are so many updates, possibilities to connect with other people and create communities, share experiences, and there are plenty of materials that you can find on our website that will help you prepare and also guide you through the activities and of course prepare you for the World Kidney Day and hopefully this World Kidney Day will perpetuate during all the other days of the year so that you can continue your mission on helping prevent kidney disease globally. I wish all of you happy World Kidney Day. Please check your creatinine because eventually this is where we are. So kidney health matters, and so checking your creatinine is the way to get there. Stay safe and take care. See you at the World Kidney Day, and best wishes to all. Thank you.
Thank you.
Thank you. Thank you.
Bye-bye.